Welcome to this webinar. Today we will talk about a new electrolytic approach to treat periimplantitis. You will agree periimplantitis is at least difficult to treat. Reducing the problem to bacteria makes a long story too short, I guess. As you can see, other things need to be taken into consideration. Bad implant axis position, tartar, inadequate soft tissue management, and other faults a dentist can cause may initiate this disease. But finally, we have to clean the implant before we treat it, and we need to design which implants can be remained or which implants have to be removed. This will be the aim of this presentation. First of all, I'd like to start to talk about the aims of a therapy. Then I will discuss current treatment concepts, the new electrolytic approach, and finally conclude. So what might be the aims of a treatment? Just removing bacteria, reducing inflammation, or should it be something else? If we see this case, we see a 15-millimeter pocket, we see severe bleeding, we see pus coming out of the pocket. And I'm a periodontist, so my normal aim when I treat teeth is I'm happy when I remove infection, when I have a non-bleeding, stable situation. And we tend to transfer the knowledge of treating periodontitis to periimplantitis. But is that really true? Is it enough if we reduce bleeding after 1 year? If we reduce probing depth, it is 3.5 millimeter less, but still 11 millimeters. And I guess you all will agree that this case will not be stable. Finally, we remove this implant 1 year later, and we need to find a consensus of what an aim could be to maintain implants on the long run. First of all, let's think a little bit. What will happen to an implant surface not covered by bone or soft tissue, which is exposed to the oral cavity? We all know what will happen. It will be contaminated by bacteria. This is on the left side of the screen. You see an SEM picture of a machined implant surface. On the right side, we see an acid-etched and sandblasted surface. We contaminated those two surfaces to bacteria soup, and you see how fast the bacteria grow on both of the surfaces. So we did never see that a smooth surface behaves better than a rough surface does. This is after 3 days, so this is not a mature biofilm, but you see the spreading bacteria, and you see what happens on a smooth and also on a rough or medium rough implant surface. So we have to realize that the bacterial colonization starts immediately when the implant surface is exposed to the oral cavity. This is not new. First is the first one who published that in 2007, so we know that for a long time. So to me, it needs to be, it is mandatory to remove the bacteria in a way that we achieve an implant surface which allows a reintegration of hard and maybe soft tissue to the implant surface. These were the requirements. And normally we judge that or we assess that by X-ray. You see the same case on the histology on the X-ray. This is a sample of a dog study we did. This implant is treated in a conventional manner. And on the X-ray, we were very happy because we saw bony regeneration proven by X-ray. But in histology, we see what happens in reality. New bone, which is not attached to the implant surface, because we did not succeed to achieve a surface which integrated, which allowed an integration of regenerated bone. So the aim for me would be to remove the biofilm completely, to regain the original surface characteristics, and finally to achieve re-osseointegration. This would be the ideal aim. Sometimes we will reach it, as I will show you, and in some cases not. And this opens up a discussion which implants should be treated and which implants should be removed. What is the etiology of periimplantitis? We all know the evidence for bacteria as a principal etiological factor is imminent. So we know that because if we remove bacteria, inflammation goes back. And all the treatment concepts which are used currently base on the treatment strategies we are used to use in periodontology. So we use devices which remove the biofilm in an ablative manner. We use air powder spray, we use polishing cups, we use curettes, we use titanium brushes. All those techniques have something in common that we try to remove the biofilm ablative. But doing that, we have to accept that we have to deal with defects which are cradle-like. We have to deal with threads of the implant which we cannot reach. Because we have cradle-like bone defects, we don't have access to the threads of the implant. And if you look to the microtexture of this implant, we have implant surfaces which allow the bacteria to hide in those surfaces. So it is not possible to clean the implants in an adequate manner. And if you're desperate enough, then you can polish the implant surface, you can grind everything away. And the disadvantage of those techniques are clear because we have a spread of titanium particles. We have the difficulty to clean the implant or to remove everything on the border to the bone. And the question is, do we achieve a reosseointegration in these cases? And in my hands, it never worked. So this is how the case ended. After 1 year, we had to remove this implant. We put it to the SEM and we found a mature biofilm on the formerly polished surface because we were not able to achieve reosseointegration, and thus we didn't achieve a stable situation. Is this only clinical feeling? No, it is not. The literature is very evident that long-term examinations didn't prove reliable results. This is a very tough review from Marco Esposito. He showed that we don't have any reliable evidence suggesting the superiority of one treatment modality. And he also proved that some of those treatment modalities had a relapse of periimplantitis up to 100% of the treated cases within 1 year. So we have to conclude that all those ablative treatment modalities do not achieve reosseointegration and do not cure periimplantitis on the long run. That's the situation we have to deal with. So our idea was, what if we have a possibility that something penetrates the biofilm and acts directly on the implant surface and pushes away or cleans the biofilm somehow? And yes, we have something what is able to penetrate the biofilm within milliseconds. And these are ions. If we load the implant, in this case with a negative current, and use positively loaded ions, they will penetrate the biofilm, and I will share the mode of action with you. This is an implant and the spray head of the device on top. With this spray head, you see this little gray metal thing which loads the implant negatively. Then we rinse the implant with an electrolyte, penetrating or passing the anode, and this causes a current between the negatively loaded implant and the positively loaded anode. And this current will cause a split of the water into hydrogen cations, so positively loaded ions, and hydrogen anions. The anions, we don't need them. they are rinsed away, and a buffer is used that the pH of the solution stays the same. But the hydrogen cations, the positively loaded hydrogen ions, take an electron from the negatively loaded implant, and then we have hydrogen. And these hydrogen bubbles push away the biofilm, and finally we end up with a clean surface, as I will prove in the next minutes. That's the mode of action of this implant device. And here you see this device acting in the oral cavity. You see the hydrogen bubbles on the whole surface, which is contacted by the electrolyte, and we see the hydrogen bubbles cleaning the implant surface. The process is only active where the electrolyte gets in contact to the implant. So it does not work in areas which are covered by bone. It works only in areas which are exposed to the electrolyte. Is it necessary to decide the brand of implant, the surface of implant, or the material which is used finally? No, it is not. It works on any surface, on any alloy, so on any brand of implants which are made of metal, of course. Now I'd like to share some studies and investigations we did on the method. These were the first trials. We had some implants which we put into the mouth of some persons who agreed to take part in this study. The implants were protected by this plastic shield. We didn't want to have epithelium from the oral cavity on the implant, and we waited for a certain time period till a mature biofilm grew on the implant surface. Now we put it to a glass and used this electrolytic approach. You see the hydrogen bubbles pushing away bigger parts. Of course, we don't see the biofilm, but we see the bigger parts. And this is the implant cleaned, which you see in the center of the screen. On the left side, it was the original situation before cleaning, so we can see a mature biofilm. And on the right side, we see a sandblasted and etched surface directly after cleaning, so we don't see any remnant of any bacteria by SEM. Again, it is not limited to a certain alloy or surface. This is another surface, a thionite surface. You see before and after cleaning, so we were not able to detect any bacteria on those surfaces. Then we asked some dentists for sending in some explanted implants. We investigated more than 400 of those implants. They came in with bone on top of the implant on some areas, and of course with a lot of biofilm. We cleaned them. This was a acid etched, no, only a sandblasted surface. In white, you see the bone. The little gap between the implant and bone is caused by SEM processing. So you can see one thing. The process worked only in areas where the electrolyte had direct access to, not in areas which are covered by bone. And if we blow that up a little bit, you see no bacteria were visible on the surface before we saw a mature biofilm. This is the implant cleaned clinically. In areas where we had bone, the bone remained because the process was not active. Just to give you another example, this is a very rough implant, a plasma flamed surface with a rough surface. And again, if we magnify that, we see bone on the implant undamaged. And if you blow up the exposed areas, we cannot see any remnant, any bacteria or nothing on the surface. So obviously we are able to clean the implant perfectly, proven by SEM. So these are the three skills we can conclude from this first in vitro studies. It removes any visible biofilm from the implant surface, proven by SEM. It works on any surface or alloy, and areas covered by bone are not affected. Now, another story, hydrophilicity. We see that if we take a new implant, place it in the mouth, then we recognize that the blood doesn't spread on the implant, it's hydrophobic. But initially, freshly prepared titanium is super hydrophilic. You see a sample of a titanium plate. It's a sandblast in an etched surface. Ogawa was the one who initiated the study. On the first day, we have a super hydrophilic surface, which changes over time to a super hydrophobic surface. So after 1 month, the super hydrophilic surface changed. Does that have any clinical relevance to us? And I will show you that this is a major issue in bone healing. On the lower graph, you see the carbon peak on a newly processed implant surface. And after 4 weeks, this is the upper curve, the carbon peak is way, way higher. So we are recognizing that the implant surface is contaminated over time by hydroxycarbons from the packaging and from the air, because titanium oxide is so active that it binds all those molecules, and this changes the surface. If you assess the cell attachment in relation to the percentage of carbon on the implant surface, then you recognize the more carbon, the less cell attachment. Here you see some example. This is a fresh prepared titanium surface and some osteoblasts which spread perfectly on this surface. And this is a 4-week-old surface. So the osteoblasts have a different shape and form, and the number of osteoblasts which grow on that is also different. So we have to realize more carbon. The more carbon, the less is the quality of osseointegration in those implants. Is that really clinical relevant? Algirdas Pushis and me, we did a study in 200 healthy patients in need of 2 implants. So 400 implants have been placed. 360 could be analyzed, and we had 6 groups. Patients were spread to those groups, randomized, of course, and in every group, every patient got 2 implants. One was test implant irradiated with an ultraviolet irradiation. So this removes the biofilm, and change removes the hydroxycarbons to achieve hydrophilic surface. And one control implant was unchanged. Then we placed the implants and retrieved them immediately and assessed the force which was necessary to retrieve it. And funny-wise, we saw a difference immediately after placing, and saw more force was necessary to remove an irradiated, so a hydrophilic implant compared to a non-hydrophilic. Then we replaced the implant, and we removed it in group 1 after 1 week, in group 2 after 2 weeks, group 3 after 3 weeks, 4 weeks, 6 weeks, and 8 weeks. We stopped at 80 Newton centimeters, of course, not to damage the implants. And in group 5 and 6, of course, we were not able to remove all the implants because they were osseointegrated, and we couldn't remove them with 80 Newton centimeters. And these are the very interesting graphs. In green, you can see the necessary reverse torque for hydrophilic implants, and in blue, the reverse torque for hydrophobic implants. What does that mean? Hydrophilic implants integrate better to bone. This was claimed by Raghavendra. He said we have a peak after 3 weeks where the dip of primary stability. He claims that an implant initially placed has a certain primary stability which decreases over time when the healing starts, and when osseointegration starts, the second the implant gets more connected to the bone, tighter to the bone, And the resulting graph in red shows you that we have a less primary stability after 3 weeks. If you look to our graph, we never saw that. Yes, we saw a peak. We saw a dip after 4 weeks, but the deepest point of the dip was always higher than primary stability. So that's a interesting conclusion out of that study. The initial primary stability will be better over time, and we never will have a dip which goes deeper than this initial stability. But what happens if we use this electrolytic approach? As you can see, this implant out of the package is hydrophobic, so the water does not spread on the implant surface. Once when we use GalvoSurge, the electrolytic approach, so we bring the implant to the solution and we apply the current, then we will see the hydrogen bubbles which clean the surface. Of course, there is no biofilm on the surface, only hydroxycarbons from the implant surface, from the packaging and the air. And as you can see now, after this cleaning process, the implant is hydrophilic again. So this proves that the electrolytic approach does not only remove bacteria, it also removes hydroxycarbons from the surface and generates again a superhydrophilic surface, which is beneficial for a re-osseointegration. Now we tested common cleaning methods and compared it to the electrolytic approach. We tested GalvoSurge versus air powder spray versus photodynamic therapy versus cold plasma and different other things. I just share air powder spray with you, which is one of the most common methods, because we have a limited time. You can see it in the published articles if you want to go deeper in this methods. We investigated always the same areas, area of interest 1 and 2, to be sure to minimize any bias. First of all, we developed a method to breed biofilm. We left it for 2 weeks. In all the other studies, the biofilm was only breeded for a few days, but we saw that we never found a mature biofilm, but with this method of 2 weeks of breeding, we achieved a very mature and difficult to remove biofilm. To make sure that the cleaning process is comparable to an intraoral situation, we applied the air powder spray with a certain angle. You see the test machine rotated and moved back and forth, as we can do that in the mouth. And now we, after cleaning that, we placed the cleaned implants into Eppendorf tubes in a nutrition solution. On the left side, you see the implant after 24 hours incubating in this nutrition solution after GalvoSurge. On the right side, you see it after air powder spray. And you see the color of the fluids are different. On the left side, it seems to be more clear. Then we spread the solution on, we plated it out on this agar plate and again incubated it for 24 hours. The aim of this investigation was to count colony forming units. So the question was, will bacteria grow again after the cleaning process? Are there any vital bacteria which survived the cleaning process? And we didn't find any surviving bacteria in any electrolytical cleaned implant. So we didn't find a single surviving bacteria. On the air powder spray, we were also not able to count colony forming units because so many bacteria grew that the whole surface of this agar plate was grown by a loan of bacteria. Then we thinned out the solution, and after thinning it out to 1 to 1 million, we were able to count colony forming units. What is the conclusion out of that study? With the electrolytical method, not a single bacteria survived the cleaning process. This is another method to prove that. This is a fluorescence test. You see a freshly produced biofilm, 2 weeks old. Every green dot stands for a living bacteria. And on the center picture, you see the cleaning after air powder spray, and on the right screen after the electrolytic approach. So again, this test proved that no vital bacteria were visible or accessible after GalvoSurge treatment. So the conclusion we can draw out of this in vitro study is no bacteria can be detected by staining or breeding in vitro. Now we started a preclinical study. 8 dogs were treated, typical model, teeth were extracted, implants were placed, 64 in all. Then we induced, after healing of 3 months, a ligature-induced periimplantitis. We waited till 4 to 60% bone loss occurred, and we treated the test implant with the electrolytic approach, the control implants with a classical approach, and we didn't treat 8 implants at all. We just removed the ligatures, and as I expected, we didn't see any difference between group 2 and 3. So between the classic approach and just removing the ligatures. So we have to discuss, is this animal model really a model which simulates periimplantitis? I guess that's not the case. Then we augmented the sites, allowed it for healing, a 3-month healing period. Then we harvested a biopsy, and I'd like to share this results. This is the control site. We cleaned those implants with a classical approach using the approach which is done in Gothenburg at the Berglund group. We used a cotton with saline, and we also used H2O2 to clean it. And then we augmented it with a mixture of autogenous bone and used the collagen membrane on top. The X-ray seemed to be somehow promising, but if you look to the histology, then we see that we have new bone, but most of the bone is not integrated to the implant. And we all will know what will happen over time when we expose this implant to the oral cavity again. We saw bony regeneration, but very limited reosseointegration. This is a very good example for relatively much reosseointegration. And I guess this was not related to the cleaning method, because when we just removed the ligature, we had the same results. But what happened with the electrolytic approach? Here you see the clinical application of the test device we used at that time. Now it's a little bit more modified and improved, of course, which was used for cleaning. And we saw, I guess this was for the first time in literature, it was published in the Journal of Clinical Medicine, a complete reosseointegration of some of the implants. Finally, I was not very happy with that study because we had a lot of exposures. I told those dogs that they should not bite on this freshly operated areas, but obviously they did not follow. So we had to deal with a high number of exposures, which limited, of course, the statistical analysis of the study. So we just reported about some evident differences, but we're not able to prove significant changes. But again, I guess this was the first time that a complete reosseointegration could be reported. So again, this was the conclusion. I never saw any complete reosseointegration before. This is the device we developed finally. It's a machine with a touch screen which allows something to change, which starts the pump, because we need the solution to be sprayed on the implant. And on the right side, you see the spray head. this little metal notch has to be in contact to the implant, and this will load the implant. And you see a little sponge. This holds the electrolyte in place. And you see this device now is very thin, so we are able even to handle narrower spaces in between some implants. And here you can see how the cleaning solution, the electrolyte, is pumped through the device and later on the implant, as you will see in the clinical cases. Now, let's start with clinics. I guess this is the thing you are interested most in. We initially, for the CE approval mark, we treated 24 healthy patients. Of course, I'm a periodontist, so we started the usual cleaning program, the strict hygiene program, till bleeding and probing was less than 20%. We removed any restorative parts. Why is that necessary? If we want to achieve re-osseointegration, then we need to have sterile implants again. And if we don't remove the restorative parts, then we are not able to clean the inner side of the implant, but we have to. And this was the reason that we removed all the implants. What happens over time if you start a cleaning program? Tissue grows over the implant, and this makes later augmentation easier. That was our idea. Then we randomized the group, 12 patients in the test group. We did, of course, periodontal probing depth. We assessed periodontal probing depth, bone sounding. We did the flap surgery. We did a smear test for PCR testing. Then we treated with GalvoSurge, and then we did another smear test for PCR testing. The same with the powder spray group, but I knew that powder spray would not work, so we, after the PCR test, we ended this group and did another electrolytic cleaning. So the study had two aims. First of all, to prove, is there a difference in PCR testing between the two groups? And then, is it from additional benefit if we use the electrolytic approach plus a classical air powder spray? After 2 weeks, we removed sutures, and after 6 weeks, we reopened the sites, and I'll share some case with you. This is the patient with a moderate periimplantitis. We removed the restorative parts, and after 2 weeks, the flap almost closed. There was a little fistula which remained. We opened a classical flap with a crestal incision. And this was the site we found. We assessed the distance between platform and bone to be able to assess differences at reopening. Then we did a PCR testing, and we cleaned it with the electrolytic approach. Again, you see the hydrogen bubbles intraorally, which are proving the effectiveness of this method. This is the clean surface. You see a coagulum. And I'm a fan of tenting techniques. As you can see, I used a cover screw 2 millimeters high, and then we augmented to the top of this 2 millimeter healing post. Why do I do that? If I augment only to the platform of the implant, then any pressure of the patient when he sleeps, when he brushes teeth, when he eats, this mobility will always cause incomplete bone healing. But if I augment 2 millimeters higher, maintained by this 2 millimeter healing post, then I will have a complete reosseointegration. That was the idea behind. So as you can see, a mixture of autogenous bone and bio-os was used to augment to the top of the 2 millimeter healing post, a classical suturing, and this was the X-ray after. After 1 week, we find the situation, and everybody of you who used treated periimplantitis before will agree that you don't see it so often, then you have no exposure. This is after 6 months, the X-ray after 6 months, which was promising. And now I share the video of the second stage surgery. And as you can see, we have now bone higher than the platform of the implant, and I never saw that clinically before. So this is a very typical situation after this classical treatment. Now the control group. We opened a site, we did a PCR testing, then we cleaned the implant with air powder spray and did another PCR testing. This is the PCR test after powder spray. Not that promising. Now we used the electrolytic approach and did another PCR testing. This was the PCR test after cleaning with the electrolytic approach. Then we augmented it with a mixture of autogenous bone and bio-os and used the collagen membrane. Classical suturing, this was after 2 weeks. And we opened the site after 4 months in this case, because this patient moved to America. So the bone is not that mature, but you can see we achieved, at least clinically, a reintegration of the implant. Of course, this does not prove re-osseointegration on a histologic base, but we proved that in this preclinical animal study before. And again, after 6 months, those patients were reassessed. We did the second stage surgery, X-rays, and a bone sounding again to have a clinical idea what happens over time. Let's come back to this case. Now we have a severe defect. It is non-contained, so we need something on top to maintain volume. I'm a fan of this umbrella technique, which also hold the tissue away and stabilize the particulated bone substitute underneath. This is the augmented side and the sutured side. The X-rays on the left side, on the right side show the baseline situation, and after 6 months you see a certain settling, but obviously we got some mineral structure almost to the shoulder of the implant. And when we open the site and remove the umbrella screw, we saw rock solid bone to the platform of the implant. I never saw that before. A more severe case. We could probe the Schneiderian membrane through this defect. I'm not sure if there was a penetration even into the sinus. The implant was only fixed a little bit on the lingual side. So electrolytic cleaning, augmenting it, and this is the situation before second stage surgery. On the X-ray base, we found bone which grew on top of the implant on the left side after augmentation when the patient left us after surgery. On the right side, the situation after 6 months. I don't understand the amount of bone on top of the implant. When we opened it, we had to remove bone to get access to the implant again. This is after 9 months, so no bleeding on probing, no pus. So we had an absolute stable situation. This is to demonstrate how we did the assessments. Before surgery, we assessed the distance from platform to bone on 6 points. And these are the things we found out. On the left side, you find the electrolytic group. On the right side, electrolytic group plus powder spray. So please remember the scientific question was, is there an advantage to use powder spray in addition? And we didn't find any statistical significant differences. So the conclusion is it's not necessary to use this in addition. The electrolytic approach is enough. Now we have to decide which implants should we treat or which implants should we still remove. You all know Frank Schwarzen's classification, which based on observation of typical defects. Now having for the first time a treatment modality which allows reosseointegration, I guess we need a new classification. So we defined the RP classification, which bases on the regenerative potential of a defect. And if we have clear intrabony defects with bone walls surrounding the defects, we expected a better healing. Let's see what happens in reality. And RP2 class would be intrabony defects with dehiscences. And extrabony defects, of course, we expect worse results. This is the results we found out when we spread the patients on these three groups. The average bone gain in intrabony defect was 4 millimeters, 2.6 in RP2 cases, and 2.3 in RP3 cases. That hints that we have to take care not to treat all the implants. Maybe those with massive extrabony defects still need to be removed, but we have too less data to have a clear treatment tree now. This is the task of future, to collect more data to give a clearer and a better recommendation which implants should be treated and which should be removed. But this was the most interesting result to me. How many implants reintegrated completely? 4 out of 4 in RP1, 6 out of 11 in RP2, and 2 out of 9 in RP3. Again, this is a hint that not any implant should be treated. I don't want to share only the nice cases. This is one of our worst. When I saw the situation, so misplaced implants and a huge defect, I suggested the patient, I could clean the implant, maybe augment it, but misplacement, it will be still an issue. Let me remove those implants, but he didn't allow me that. So I cleaned it and treated it. And this was a bad outcome in our study. But even with a bad oral hygiene, I mean, he had no access, no perfect access to this area. There was no pus and a little bleeding, a little mucositis, but we didn't see any periimplantitis in this case. So now we need to discuss what is success and how can we assess success. You may be aware of this study. I, as a periodontist, like apical reposition flaps in difficult cases because I remove the pockets. And in perio, this is a very promising method to achieve a stable situation. So in this study, implants were treated with apical reposition flap, and they defined 3 outcomes. Outcome 1 was no further marginal bone loss more than 0.5 millimeters. So they still accepted bone loss. Outcome 2 was outcome 1 plus probing depth less than 5 millimeters. And outcome 3 was outcome 2 plus no bleeding and no pus, so no inflammation. Let's see what happened after 3 years. Outcome 1 was around 70%, but the most interesting thing is outcome 3, only 1/3 of the implant didn't bleed. So what does that mean? Even the apical repositioned flap stabilizes only 33% of the implants. Now we said we define outcome 4, which is outcome 3 plus gain of attached bone, and outcome 5 is complete regain of attached bone. And these were the results. We lost 1 implant in the study, or after the study, directly after the study. I removed it after 8 months. In 11 implants, so 45% or 46, we achieved outcome 4, and in 50%, we achieved outcome 5. This is only after 6 months, I have to admit. So we have to see what will happen after 3 months. But now I have almost 3 months of clinical experience, and we are working on the long-term articles. And I can tell you one thing, it didn't change so much over time. Let's share some cases. RP1 cases, so the easy cases with completely bone walls surrounding the implants. But the defect was very deep, and the defect was also very wide. So as you will agree, this is not a defect which heals by itself when you just clean the implant. So we augmented it with bio-os and autogenous bone. You see the X-ray directly after healing. So we had a bone loss almost to the tip of the implant. This is the sutured site healing. some particles penetrated the flap over time, but you know that by yourself that this might happen. And this is the clinical result after 6 months. And this is after 9 months. Sorry, after 6 months also. This was before. And this is the X-ray after this time. And you see the history of this case. Started in 2011, 14 and 15 we treated it. You see the situation before. We opened the flap, we found this site, so a deep defect, but an RP1 case. I'm using PRF for these cases, augmentation with autogenous bone and a bone mineral. Again, a collagen membrane and PRF membrane on top. This is the X-ray directly after healing, the healed site. And now to give you a feeling of the bone, I guess a video is better to allow you a realistic assessing of the situation. And we find a hard bone, removing the cover screw. And now we are able to save the old restorative parts and to replace them. And this is a big advantage of this method. Imagine you have a case with 8 implants and a restoration on top of that. You did the implants, and now one of the implants, the central one, which is necessary for stability, or the last one, has a periimplantitis. Imagine what you can save, or the patient can save, if you can save the restoration. This is after suturing, and now we follow up the patient. This is 2019 now. We have a really stable situation over time. Now let's see a typical RP2 case. The buccal wall is missing in this case, and this is more difficult to augment, as you will agree. So another issue is the containment of the implant. When we remove the crown, we find very often a situation like this. Dirty implant inside. Depends, of course, to the connection. A platform, a flat-to-flat connection is worse than a conical connection. We know that. But the question is this method able to remove that? And I'll share this little video with you. First of all, we remove the granulation tissue. It's very easy. If you work to the bone, don't pull on the granulation tissue, that it will tear and it takes more time. Work to the bone, and then it's very, very easy to grab the whole granulation tissue with a forceps and to remove it. And then you can start cleaning the implant, remove the cover screw. First of all, we assessed, of course, the amount of bone loss. And this was the situation before cleaning. We cleaned it with the electrolytic approach. And this was the situation after cleaning. So this demonstrates you that the device is also able to clean implant containments. And now we have to augment it. Lingual bone wall is there, buccal is missing. Again, I used a tenting screw, a collagen membrane, and the healing, and now we had exposure in this situation. And I will share the pictures over time. This is after 2 months. We instruct the patient to clean that, of course. This is after 3 months. This is after 5 months. Then we removed the cover screw after 6 months. No bleeding, no pus, absolutely stable situation. This is a very typical bone situation for this implant, for this kind of implant. Now we replaced the old crown. This is 24 months now, no bleeding, no pus, and the lingual aspect. Of course, we had some recession in this case, which also needs to be taken into consideration. And the X-ray after 24 months. We have more and more cases which we follow up for 2 years now. And again, the study will be finalized within the next weeks. and submitted for publication. RP3 cases. Again, cleaning is easy, but the question is, can we augment those cases? Again, we are using those umbrella screws to maintain space, because if you want to regenerate bone, then you need immobile space. You can also use other techniques, of course, titanium meshes, reinforced titanium Gore-Tex membranes, or whatever you prefer. I'm a fan of those umbrella screws, which make my life much easier than the techniques I used before. The situation before second stage, and this is the healing we achieved. Not that complete, but almost complete. And another case, the defects are getting bigger and bigger, as you can see. We cleaned it. I don't think it's necessary to share the same. This was the control group. And then after we did an electrolytic cleaning, of course, and the healing, the X-ray after augmentation. And of course, in this case, we had to suffer an exposure. This was the site after reopening after 6 months. The umbrella screw almost integrated in the augmented bone. And as you can see, severe bone growth was assessed. When you remove these umbrella screws, you normally find this 0.5 millimeter thick connective tissue. This little donut-like structure is caused by micro mobility of the screw. But we achieved a very stable situation over time. This is 6 month results. No, sorry, 3 month results. No bleeding, no pus. And this is an 18-month results. So an absolute stable situation, despite it was an RP3 situation. Okay, of course, I treated now around 130 cases, which I follow up over time, but things are open to be discussed. So the first question would be, do we need submerged healing, or is open healing also possible? With this type of tissue level implants, of course, it is not always possible to cover the site perfectly. I don't have so much experience with that. I treated, let me say, 15 cases. The follow-up period is not long enough to show you results, so I will not do that. I just discuss that in this moment. But of course, we will come back in 1 year to share those experience with you by an article or maybe another webinar. Just to give you the things we are working on now, this is an RP3 case. We are not able to augment it because it's a tissue level implant. We clean it and we augment it to the site using a collagen membrane. And of course, we are using an open healing approach in this case. We rescrew the crown immediately. And this is the site, the situation after 3 months. And clinically, it looks very nice. But now to the failures. I told you we had to remove one implant directly after the study. It was this case. And as you will see, it is a really fascinating case. The implant is misplaced. The axis is much too far to the lingual aspect. And of course, looking back, I should have removed the implant. But I tried to treat it with the described techniques. We augmented it and we had an exposure. And we tried to maintain it. The patient did not brush very well, but this was the situation. And finally, we decided this will not be stable over time. And we opened the site and removed the implant. We found a lot of new bone clinically. And now we had the chance to get to have a human histology for the first time. So we sent the sample to Dieter Bossart to the University of Bern, who did the histology. And as you can see, we found a lot of new bone. Old bone is a very mature bone. And on the upper side, you see re-osseo-integrated bone. to the implant. I guess this is the first clinical proof of re-osseointegration worldwide. This was the other side of this implant. So we achieved a lot of new bone and a lot of re-osseointegration. Over time, we had to remove 3 implants. A 4th I removed now. It is for sent out for preparation now, but this is case 2. And again, you see bone mineral particle very well integrated in the re-osseointegrated areas. So again, re-osseointegration. Here are some particles of titanium, which were in the tissues, obviously, but we didn't see any issue and a complete re-osseointegration. And this is the most interesting histology I ever saw, because this is a re-osseointegration of calculus. This was an area which was exposed, covered by calculus. Of course, we try to remove it, but it is difficult to remove any calculus from the underside of any thread in a crater-like bone defect. And so we were always a little bit afraid what will happen with undetected calculus. And this is the answer, the first clinical histology of re-osseointegration on an implant and on calculus. So obviously we expected that. This method also sterilizes this area. Okay, but it is an issue, of course. How can we remove the calculus without destroying the surface? Any method to remove the surface changes the surface of the implant, but this is an open question we have to solve. But finally, we didn't see so many impact on the results when we did that. And of course, we still have to answer how much re-osseointegration is possible in those cases. Of course, Istvan Urban will be one who will provide us techniques to mobilize the tissues in an adequate manner to cover those sites with passively sitting flaps. And of course, another issue is there. Not only the implants and the bone are infected, but also the soft tissue. And we still do not know how this infection compromises the healing process in some times. To summarize that, I guess we proved for the first time worldwide that a complete regain of bone clinically in implants is possible. And also on 3 cases now, but soon on 4 cases, we proved that we have a complete, we have a re-osseointegration even in implants which failed after therapy and we had to remove. Below you see the team. Holger Ziprich was the engineer and was Broadbeck. The 3 of us developed the whole story. Rocher Eberle is the CEO of our company, and the other guys developed the device clinically. With this, I'd like to thank you for your kind attention, and I'm open for questions now.